there, I'm Emily Boss. I'm an otolaryngologist, head and neck surgeon. That means I'm an ear, nose, and throat doctor in layman's terms. What that may mean to you is when I finished medical school, I completed a 1-year internship in general surgery, followed by 4 years of training in otolaryngology, head and neck surgery. I specifically am a pediatric otolaryngologist. I obtained a 1-year fellowship training only in pediatric otolaryngology. Today I'm going to teach you the basic head and neck examination. Follow me. Hi, Miss Williams.
Hi.
Nice to meet you.
Nice to meet you too.
I'll just wash my hands here.
Okay.
I'm Dr. Boss. It's great to meet you. Do you go by Miss Williams?
I go by Charlene.
All right,
That's
Charlene.
fine.
Is it okay if I examine you?
Sure.
Okay. Char, if it's okay, I'd like to share with the students the basic components of the head and neck examination.
Okay.
All right. So there are several components to the head and neck exam. First, we start by looking at general constitutional signs, as well as symmetry of the face, facial features, shape of the head, and a basic examination of the scalp. Next, I'll look at the external ears, also known as the pinnae, and then I'll evaluate the tympanic membrane using otoscopy. Next, I'll look at the nose, both the external nose and the internal nasal cavity. I'll also evaluate the oral cavity and the oropharynx. Finally, I'll evaluate the neck, which includes an examination of the lymph nodes, the thyroid gland, and the salivary glands. The patient is typically seated and comfortable. We are standing at eye level with the patient, and the good news about head and neck is the patient can typically wear their own clothing as long as I can evaluate the face and the neck. As you can see, my very nice patient, Char, is seated comfortably with her knees bent. I'm at eye level with the patient, and I'm making a mental note right now to look for facial features and facial symmetry. At this point, I would also do a basic cranial nerve examination, and I'll refer you to your neurology lecture for that moment. Let's move on to the ear exam. First, I'm going to evaluate the bilateral external ears, also known as the auricles or pinnae. Specifically on Char's ear, I can see several important structures, including the helical rim, the antihelix, the tragal cartilage, the lobule, and the conchal bulb. I'm also looking at the general patency of the external auditory canal. I'm looking for any kind of accessory pits, tags, cysts, or deformities. Now I'll show you the otoscopic examination, where we'll evaluate the ear canal and also the eardrum, which is the tympanic membrane. We typically use a wall-mounted otoscope, which here I can demonstrate here. This is a pneumatic bulb. This can be very useful in an examination setting, particularly with children, and this is used to basically assess for mobility of the tympanic membrane. I hold the otoscope like it's a pencil to have ultimate control of the otoscope as I approach the patient. For me, that means I'm holding it so that the otoscope sits directly on my fourth finger. As I approach the patient, I usually hold my pneumatic bulb in my left hand, and I reach my pinky out so that I can stabilize my hand on the patient's face throughout the examination. I will gently grasp between my first two fingers the patient's outer ear, and I lift the ear backwards, and this is to straighten out the ear canal just a little bit. Now I carefully insert the speculum in Char's ear canal, and I very gently angle the speculum anteriorly or to the front, and this is to gain maximum view of the tympanic membrane. It's very important not to approach the patient with any kind of erratic motion, and also not to move the speculum so that it hits the back wall of the ear canal with any kind of force. If it does that, it can be very, very painful to the patient and make the rest of your exam somewhat more difficult. So allow me to demonstrate what all of that looks like. I evaluate the right external ear, approach Char, gently lift her ear back, and now I can see the tympanic membrane and the external auditory canal. I will typically switch hands for the other ear. Again, looking at the eardrum, assessing for mobility, just like that. Okay, now let's examine the nose. I'm going to stand just to Char's right, and then I'll gently position her head so it's facing me. Again, anytime we're approaching the patient's neck and face, we want to be very controlled in our motion. I'll typically take my left hand, position it on the patient's forehead, and then gently upward turn the nasal tip. Now again, holding the otoscope in a controlled fashion, I position my pinky on the patient's chin so that it's stable. And I carefully evaluate the mucosa of the nose, the inferior turbinate, looking for any kind of crusting or purulent disease, polyps. I evaluate whether or not the nose itself is patent and if there are any septal abnormalities. And again, the septum is that middle wall of the nose. I'm also noticing that the patient is breathing very comfortably through her nose with her mouth closed. We'll examine the mouth and throat, which are also known as the oral cavity and the oropharynx. The oral cavity consists of the lips, the gingiva, the teeth, and the front part of the tongue, as well as the hard palate or roof of the mouth. The oropharynx refers to the soft palate or soft roof of the mouth, uvula, tonsils, and the base of the tongue, as well as the walls of the pharynx or the throat. I'll approach Char, and I have a tongue depressor ready for my use. Is it okay if I look in your mouth?
Sure.
Okay, open wide. I'm going to gently use my tongue depressor to deflect the lips away from the teeth. I'm looking for the quality and color of the mucosa or the skin on the inside of the mouth. I'm also evaluating the Stenson's ducts, which are the ducts for the parotid gland on the insides of the cheek, right by the second upper molar. Char, can you say ah for me, please? So here I'm looking at motion of the soft palate, ah again, and also looking for symmetry, and I'm evaluating the tonsils, which you can't see very well on Char. Say ah again for me. I'm going to place some gentle pressure on the tongue. The tongue depressor can certainly gag a patient, so you want to have a very careful fulcrum-like motion on the mid portion of the tongue. Ah, one more time. And this will improve your visualization of the posterior pharynx or oropharynx. The tonsils are very small over there. Lift your tongue to the roof of your mouth, please. Just lift your tongue to the roof of your mouth. And now I'm evaluating underneath the tongue, the floor of the mouth. This includes the ducts to the submandibular gland, also known as Wharton's ducts. Char has an interesting finding here, benign bony prominences along the bone of the jaw or mandible. These are called mandibular tori, and they're of no consequence. Good job. Also, just like to point out to all of you that while I won't demonstrate a palpation of the oral cavity and oropharynx on Char, we do typically palpate the oral cavity and oropharynx, assessing for any kind of asymmetry or mass lesions. In this circumstance, I would glove my right hand and again stabilize Char's head and neck with my left hand and very carefully palpate the floor of the mouth, the gingiva, and also the base of the tongue. And this is really to evaluate for anything that's atypical, including a carcinoma. Okay, Char, now I'd like to demonstrate examination of the neck. I'll approach the patient, and again, I'm right-handed, so I'll stand on the patient's right side. And I'm going to start by evaluating the parotid glands on both sides. And I like to perform bimanual or two-handed palpation because then I'm able to assess for any kind of asymmetric process or lesion. Now I'll move my hands so they're moving into the submental, which is directly under the chin, and the submandibular chains. And at this point I can also palpate the submandibular glands. Now I'll feel for the tonsillar lymph node chains and carefully move my hand down the patient's neck in front of the sternocleidomastoid muscle, or the largest muscle in the neck, to feel the anterior cervical chain. I'll branch out. I'm just going to duck under here and feel your lymph nodes by your shoulders, and I'm feeling the supraclavicular chain directly over the clavicle. And now I'll inch my fingers to the back and move along the posterior cervical chain up to the occiput. Finally, let's evaluate Char's thyroid gland. First, I'm going to stand in front of her and ask her to gently lift her chin, and I'm just inspecting the region of the thyroid for any kind of prominence or asymmetry. There are multiple ways to approach the thyroid exam. I'm going to teach you approaching the thyroid examination from behind the patient. I'll place my hands around the front of the neck, and I'm going to carefully palpate the airway, which is in the midline. I'm feeling for the cartilaginous landmarks of the neck, including the thyroid and the cricoid cartilage, and then placing the pads of my finger on either side of the trachea in the region of the thyroid gland. It's helpful to have your patient have a cup of water in her hands. Char, would you mind taking a sip of water for me and hold it in your mouth? And now give me a good swallow. At this point, I can feel for elevation of the thyroid and cricoid cartilage, and this may help to make the thyroid gland more evident. And I'm feeling for, again, any kind of asymmetry, lumps, bumps, nodules, or enlargement. With Char's help, I've been able to show you a very basic examination of the head and neck. Feel free to come and contact any otolaryngologist, head and neck surgeon, and we'd love to show you what we do. Thank you so much for your help, Char.
Thank you.